questions? Senator Carroll.
Thank you, Mr. Chairman. Talk a little bit about the billing aspect of these services and how that works.
So as of right now, some of it is fee for service. And so what we're looking for is within the ACO model, right, where a lot of it ends up becoming quality measures, right? So we end up looking at this and billing that. There's fee for service models as of right now. So.
And I think if you look at the community action, they're already being paid to provide these services, so it wouldn't be any different billing. They don't submit a bill for those. They get a grant or a chunk of money. But now instead of one person having to drive to one county to see 10 patients, one person in the same hour can see 10 patients in every county that they serve. So there's no billing increase for them.
Okay, but for physicians' time, it would just be standard billing rates?
Correct.
Okay. All right. Thank you, Mr. Chairman.
Senator Alvarado.
Thank you. I'm a fellow MedPeds physician, so it's good to see a colleague who has got the same training. Basically, the concern I've got, I know some other states have issues when it comes to any kind of telemedicine, is having either out-of-state physicians providing services. I know it's not as concerned when you're kind of in the middle of the state, but when you get near the edges of the border, is either having states or physicians that might be out of our state, not licensed, and providing care to people here. Is there anything that we have as far as any safeguards to make sure that we have doctors that are licensed and to make sure that they're not practicing out of state, providing services for people here, you know, kind of long distance?
Under the current law, just because the cabinet has such few areas that they approve as a telehealth center, yes, those safeguards are in place. As we expand it in any proposed change to the law or the regulations, we would have to put that piece in place and make sure that they were qualified providers, whether physicians or RNs or counselors, whatever their particular piece was.
We're getting reimbursed now. Obviously, you can do a lot of services. I know there's surgeons that have robots in hospitals now that are post-operative kind of machines that roam around. It's like a little robot with his face on it, and it can check patients out. It's got, you know, closed-in lens. You can look at wounds very close and all kinds of neat little things like that. What you guys are referring more to is just on the behavioral side of this, is just more or less conducting the visit long distance is the main thing that you're talking about. I mean, obviously you can monitor a lot of people that have heart failure as far as their weight changes and all that, but you're talking about people going to a closer location to get those visits in terms of closing the gap of lack of access in our rural areas is what we're referring to here.
Correct.
Okay.
And some states are even looking at direct-to-patient, although that's a little harder, where the patient is actually in their home.
What restrictions do we have right now to do this now? I mean, is there any, I mean, I know you're coming here to present. I'm assuming it's because you're wanting something past or something in the future. But if we're reimbursing that, are there roadblocks that we're encountering in having this done?
They're not reimbursing. They may be reimbursing what the doctor is doing. They're not reimbursing counselors long distance unless you're in the CMHC, and they're certainly not allowing the community action to leverage their pass-through money that way.
Okay,
and also the monitoring aspect, right? So actually putting devices, like none of that stuff is actually being reimbursed. It's really just, as they say, a face-to-face encounter, which would be a physician actually interacting with the patient. So actually putting in place the tools for the monitoring, there's no reimbursement for that right now.
Gotcha.
So.
And obviously for the ACOs, this is huge just in terms of trying to reduce readmissions to the hospital. We've heard about it earlier today and during this committee hearing as well. That's going to really help. If you can catch somebody before they lapse into heart failure and make the changes from a distance, it's really going to help as far as getting them out of the hospital. Thank you, Mr. Chairman. That's all.
Representative Brown. Oh, I'm sorry. You're on. Yeah, you're on. Senator, I'm sorry.
This might, doesn't a lot of this depend on how effective and efficient you are in terms of getting our broadband access networks?
That is a very good point, and yes, we had discussed that, in fact, right before the meeting.
I mean, because I'm looking at your last two sentences here, which says that it is vital to technology upgrade that the cabinet is working on with its projected completion date of 12/15, including capacity for telehealth service interaction. The cabinet cannot effectively support and oversee such services as they expand in the coming decade unless this system is put in place. So how soon we bring our broadband network on in this state relates to how effective you can be in terms of providing telehealth services to all people.
Absolutely. It is a fact that will certainly increase access. There are regions of the state where it is hard to have access with a cell phone or even with Wi-Fi. I don't think we need to wait on telehealth changes for broadband. Hopefully we can start with what we have and keep building, but that is a fantastic point, yes.
I'll say there are also multiple places, even in Mississippi, where the rural areas didn't have broadband access, and through the implementation of a lot of these programs, some of those services with the local providers actually end up beefing up local infrastructure.
In fact, I'd point out Community Action was directly involved in the broadband project that had been going on in Kentucky for the last 3 or 4 years now, and one of the things we provided is computer access and broadband access within our outreach offices in areas where there is deficient broadband or not sufficient broadband access for individual users. So we have actually been supplementing broadband access for several years on that issue, and we see that to be in a natural position for us to supplement with telehealth.
Through the telehealth legislation years ago, and quite frankly, none of us knew what we were doing, which is probably what's going on today.
No, you did a great job.
Some of the questions that members asked today are very good questions, and one is about who's on the other end of that TV. Are they qualified to have the credentials and everything for it? And I know it's going to work, and I know people working together to make it work, but you know, if you can get a satellite 250 miles up in the air and drop a bomb in somebody's pocket, that's pretty good stuff. And it's a matter of, I think, people getting used to it, how you figure out how you bill for it, and those type of little things that probably don't enter most people's mind. But I think it's a good thing, and I thank the members for their good questions today, because it's something that maybe we should have asked 10 years ago when we did the legislation, but it seemed like a good idea now, and I think it's even a better idea now. Thank you all again for coming forth. Appreciate it.
Thank you so much.
Last but not least,